Hi, I'm Mike Gibson, and welcome to TCT Crossfire. Today we have two guests, Dr. Magnus Ohman from Duke Clinical Research Institute and Duke University joining us, and Dr. Germano Di Sciascio. Welcome, Germano. Welcome, Magnus.
Thank
so,
you.
Today's topic is pre-PCI thienopyridine therapy or loading necessary for most cases? And Magnus, you're going to lead us off with the pro point of view.
Yes, Mike, I believe so. And the reason is that if you look back at the early trials of clopidogrel and you examined the timing of the dose and the outcomes in the trials, what you'll find is that by and large, preloading with clopidogrel actually is beneficial. That is to say, the outcomes appear better the earlier you load. However, with the newer agents that we use a lot now, prasugrel and ticagrelor, we have none of that data because all the trials were actually loaded before the PCI and they're much more faster acting. So we don't have the same sense of exactly the timing of this. So from my vantage point, I think with the newer agents, I think it's probably true that it is so, but we have relatively little data. We have one trial, a COAST, that looked at prasugrel timing. But remember, everybody got prasugrel preloaded, half dose versus in the lab, full dose. So it's really sort of a timing issue. So from my vantage point, I think it really works.
Okay, Germano.
Well, first of all, I would like to make a premise. I'm impersonating the role of antagonist against Magnus, even though I may be in agreement with some of the things that he says, not everything. My personal bias is that there is a degree, there is a gradient in severity of ischemic syndromes that goes from stable syndrome, stable angina, non-ST segment elevation of myocardial infarction, ST segment elevation of myocardial infarction. This is paralleled by the likelihood of finding an acute lesion which would require stenting, basically of confirming the diagnosis and stenting the lesion. So the higher the likelihood of performing a stenting on the patient, the more the need of a possible pretreatment, like we do in myocardial infarction. In myocardial infarction, the latest European Society of Cardiology recommendations of 2014, they came out a couple of weeks ago, presented at the European Society. In myocardial infarction, I was saying preloading with ticagrelor or prasugrel is recommended, or clopidogrel when they are not available, class 1B recommendation. In stable angina, the other end of the spectrum, preloading prior to knowing coronary angiography is not recommended. It is instead recommended loading after we make a diagnosis with recommendation 1A with 600 milligram of clopidogrel. Here is the other objection that I'd like to do to Magnus, the fact that most of the studies that he quoted, those early pivotal studies, utilized 300 milligram of clopidogrel, which I'm not sure is always adequate in the lab. So we really need to look at the amount of dosing that we utilize. In the middle, there is the non-ST segment elevation of myocardial infarction. And we know that in non-STEMI, it's not so sure that we're going to find a stenting requiring lesion. 10% are normal, 15% are treated with medical therapy, 10% go to surgery. So maybe we can wait and treat in the lab after we make a diagnosis in order not to expose the patient to unnecessary complications of bleeding and surgical bleeding and so forth if we preload them too early. And on the other hand, if we take them to the lab pretty quickly, which is what we do now, faster times, stronger and faster acting antiplatelet agents, we can wait an hour or two before we load them and not expose ourselves and the patients to a bunch of problems, especially bleeding problems.
Sure.
That's my view.
Well, Magnus, the data that you cited was really observational data. I mean, you can't really cite randomized trial data to support your point of view, can you?
No, and that wasn't the
And you're a
plan.
trialist.
Yes, and I'm a trialist, but I'm also a realist, and that I think this is, the whole debate here is really, if you talk about clopidogrel, it's a much more real debate. With the newer agents, prasugrel, ticagrelor, they come on board so quickly. So even if you give them at the time of the procedure, they're active. They still work. Whereas that's not the case with clopidogrel. So I think it really depends, and I have to agree with Germano, that in a way, when you look at the older data, it's flawed partially because we're dealing with inferior agents. Now the question becomes then, if you don't preload, and you have various conditions, the condition that's probably the most important one is ST elevation MI, where it's actually hard to preload. And the Atlantic trial, just recently presented at ESC, it actually didn't show any difference in the primary endpoint, which was ST segment resolution. I don't know that we really thought that would really matter. But interestingly, in the stent thrombosis data, in a randomized trial of preloading versus not, it actually made a difference. It was significantly less stent thrombosis. So I agree completely with Germano. It depends somewhat on the clinical condition. And if you're going to stick with an older agent, yeah, it does matter. But the newer agent is much less of an issue.
Final thoughts, Germano?
Final thoughts are that the lower the risk, the lower the benefit in preloading. You don't gain benefit, you just get the complications without really improving the PCI outcome, and vice versa, of course. As we have demonstrated in the Armida 5, which is a study that utilized moderate risk patients and showed no difference whatsoever in preloading or loading in the lab patients with those clinical characteristics. And the Prague 8, which is another European study, showed that if the patients don't go to the lab, and 1/3 of them only went to the lab, they only get bleeding without benefit.
Twice as much bleeding, actually. Yes. All right. Thank you, Germano. Thanks to both of you for joining us at Crossfire today. And thanks to all of you out there joining us here live from TCT 2014.